Our next speaker is Dr. Martin Schulze, who will discuss on molecular genetic diagnostics in breast cancer patients, insights from a real-life cohort. Beforehand, I'd like to invite Sanwar Hussain of CGAT, who will introduce our presenter and the presentation also.
And I'm Mohammad Sanwar Hussain. I'm the country director of CGAT Germany. I'm working from Germany, but I'm now in Bangladesh for some days just to attend the conference and to create some awareness in Bangladeshi patients and doctors for genetic diagnostics. So I would like to welcome Dr. Martin Schulze for the presentation on molecular genetic diagnostics in breast cancer from a real-life cohort. Thank you. Please, Martin.
So hello everybody, I hope that you can hear me well, you can already see me. Is audio quality okay? All good? So you do hear me?
Yeah. Yes, Martin, we can hear you.
Thank you. I will start sharing my slides and start with talk afterwards. So very well. I hope you do see the slides in presentation mode right now.
So Martin, it's not in the presenter view. If you can make it presenter view, then it should be fine.
Okay. So, first I would like to thank the organizers for giving me the opportunity to talk to you in Bangladesh. I unfortunately cannot be there in person, and hopefully this Zoom session will do it. And I'm happy to present my data now. I'm a full-time employee of Center of Human Genetics in Tübingen and have no conflict of interest to declare. Just a brief introduction on who we are and where we are. We are right in the center of Europe, on the southern part of Germany. The Center for Human Genetics has roughly 200 employees, and we offer germline testing and somatic tumor diagnostics. Patient collective is the cohort is mainly from Germany, but we also got international patients in the cohort, which are kindly provided to us by CGAT, our partner for international patients. And as I said, we are doing German and somatic diagnostic testing. So this is a real-life cohort, no selection, no inclusion criteria. It's just what we receive in daily routine. We're talking about breast cancer. We received 3,719 cancer patients, among them for germline testing. So the question here is hereditary cancer. And for somatic diagnostics, we got far more patients. We got roughly another 1,000 patients that come to us and getting the tumor tissue tested with the idea of finding molecular markers that may be usable for therapeutic options. And there we do tumor normal comparisons, so we sequence tumor alongside with germline tissue. The minimal amount of genes that we are checking for mutations is 120 roughly in germline testing, and the tumor panel we used has roughly 700 genes, a bit more, and always includes all the genes that we are testing in germline as well. So all somatic analysis also gives us full insight on what we would retrieve if the patient were only brought to us for germline testing. So that's not a problem. Germline is always tested along. Of course, for breast cancer, it's all about core genes, one would expect. The diagnostic yield is defined as we did find a pathogenic or likely pathogenic variant according to the ACMG or ACGS criteria, so that would be class 4 or 5 in this system. And we did get a diagnostic yield in germline testing, so for those patients that did receive molecular genetic testing due to a possible hereditary breast cancer disease, the core genes made up summed up total to 11.23% of diagnostic yield, and the core genes BRCA1 and BRCA2 alone are roughly half of, or a bit more than half of diagnostic yields. But what we did see, since we test a lot more genes than those core genes, there are another roughly 6% of cases which show with pathogenic, likely pathogenic variants in other genes, but the core genes that are displayed on the right side of the slide. Just a quick remark: if you got a solution rate on the top of your mind, we're not specialized for HBOC patient care. It's just that we do not enrich for familial HBOC cases. They're just among our cohort, but we're not a specialized center for breast cancer, so we go for all solid cancers, and that's why BRCA1 and BRCA2 may yield roughly 1% less than expected. So how do our solution rates are grouped among the genes? So I already told you that core genes, HBOC core genes, make up the most yield, but it's very interesting to see that other, also the more dominant genes and Lynch syndrome in special, do make up quite a high percent, 2.1% of additional potential diagnostic yield, which is unexpected, I would say, since breast cancer is always thought about from the collection of the core genes that are very well known, and a lot of people also do diagnostic testing for breast cancer patients by only checking for mutations in the core genes. We got also a couple of recessive genes with single heterozygous mutations that we stumble upon when we are checking for mutations in our panel. It should be mentioned that a single variant and a recessive gene will most probably not be the causative reasons or not be the molecular cause of disease. So I would not really focus on those, but the group of genes marked with a star are really of interest because they provide potential differential diagnosis. What we find is in line with what people find when they go for larger cohorts. So our data were also used for the publication here. And as you may see by the gene names listed on the bottom of the slide, that especially Lynch syndrome genes and other autosomal dominant tumor predisposition genes make up case solutions outside of what is expected to be a breast cancer core gene. We also analyzed German, as mentioned before, for those patients that came to us to receive tumor tissue testing for mainly finding more therapeutic options within the tumor by analyzing all the mutations that are present in the tumor tissue but not in the germline tissue. So what is the mutation that is actually driving the tumor? All these patients, or the collective, the patients already suffer from breast cancer. And since they are not introduced to our institute mainly for germline testing, I would assume that in this part of the cohort, more sporadic cases are that are not affected by hereditary cancer. But if we take a look at the solution rate and check for pathogenic germline mutations in those patients that are primarily diagnosed with a focus on somatic diagnostics, we see that there's the same thing that we already observed in the germline-only cohort. A lot of genes are HBOC core genes that are indeed showing with a pathogenic variant. And again, we find even more potential case solutions outside the spectrum of HBOC core genes. And if you take both cohorts as subcohorts side by side, I think it's more or less expected that the solution rate in the core genes is a bit higher if the reason for molecular testing is familial history of cancer, while it is a bit smaller for those patients that did receive molecular testing due to an active tumor. But anyhow, I think that's quite impressive to see that a lot of suspected sporadic cases do show up with germline mutations and therefore are not affected sporadically. When we now switch the focus more on the side of molecular testing of tumor tissue, there are a lot of biomarkers that we always analyze along, so it's not only detecting mutations like SNV or CNV, we also try to go through the data to determine a certain set of biomarkers that are displayed here. For breast cancer, one of the most important biomarkers would be homologous recombination deficiency, but we also check microsatellite instability, we calculate the tumor mutational burden. We screen for viral infections as a standard routine thing, and we got an additional option that I would like to focus on in the first slides a bit is we go for fusion diagnostics based on RNA sequencing. So we isolate RNA from the tumor slice, from the tumor tissue, and check if there are any gene fusions, which is not really expected for breast cancer because gene fusions are more seen, let's say, for lung cancer, not for breast cancer. So let's see what we found. We got a relatively high proportion of HRD, homologous recombination deficiency, that's a bit higher than expected. We also did find cases that show or that present with a high tumor mutational burden. Only a very small percentage is MSI unstable, which is a bit surprising since we also got lymph patients in those cohorts as presented before, but maybe some of those patients that are definitely being affected by lymph syndrome do have breast cancer as a sporadic disease because hereditary predisposition does not necessarily mean that you will never get a tumor spontaneously as the rest of the population. We did not find, as expected, any cases that present with viral infections. But what we did find is a relatively high number of tumor tissue where gene fusions did appear. So 3.6% of all analyzed samples, of all tumor samples analyzed, did present with a potentially therapeutically relevant druggable gene fusion. I displayed them on the far right side of the slide. These events are mostly unique, and there are two passive mechanisms involved. The one that is expected is the fusion leads to the activation of oncogene like ESR1 or FGFR2, where druggable, that represent druggable targets. But we also got rarely the inactivation of tumor suppressor genes, which means that the gene fusion did occur, but instead of leading to a functional protein, it inactivates the tumor suppressor gene and is therefore driving cancer. Fusions of unknown significance are also quite frequently observed, which we believe to be due to HRD, which is kind of shuffling around parts of the genome that are not to be shoveled in healthy tissue, and that might lead to fusions whose effect or whose pathogenicity we cannot judge on. Finally, I would like to present to you what is the top 30 genes affected in somatic diagnostics. So we do tumor sequencing and check which genes are frequently found, and it's the number of patients that you do see here on top of the bars. And not so surprisingly, TP53, PI3, ACA are genes that are affected, that's expected. And here is what drug classes can be taken as a rationale from this mutation profile. Here's the top 30 mutated genes in somatic diagnostics. And in green, I highlighted those that will present with in-label druggable options. So the green ones, there is drugs available which are according to FDA and EMA, so the American and the European approval organizations are druggable and druggable in line, so no off-label use. That's the genes that I refer to. This is highlighted in orange here. And here's a couple of drugs that can be chosen from, since they are approved to use for these biomarkers, for these genes mutated. That's only a selection, there are far more. And that's why we always would recommend that when it comes to therapy decision making, to get into a molecular tumor board. A far majority of patients that receive breast cancer patients that receive molecular testing in-house are already more or less done with standard of care, so they reach out to us because all the standard chemotherapy already failed, and there's a question if there's a molecular rationale for going on with therapy that has not necessarily been part of the standard of care that they already received. So what is the conclusion and the take-home message from which I hopefully convinced you to share is we think that it is needed to go for comprehensive panels, not only core genes, because there are case solutions that will be overlooked if you only focus on the core genes. For those patients that are already affected themselves, we always recommend to go for germline and somatic testing in parallel. Why do we do that? Because only by tumor normal comparison you can really understand what drives the cancer. I already mentioned earlier is that some tumor predispositions may be detected, but they do not really cause the cancer. And this is something that you will only get behind when you really take a look at the somatic profile of the tumor itself and see if it presents a driver or not. For example, if you have a Lynch syndrome patient who does not show with high TMB and MSI, then potentially the Lynch syndrome does not cause the cancer, but the patient is infected by sporadic cancer instead. For somatic diagnostics, that was, at least for me, an eye-opener. Fusion detection should be done. It is not standard of care, I would assume, but perhaps it should be because 3-point-something% is quite a high number, and druggable fusions represent really a valuable target because they are quite effectively used for patient care because they really harm the tumor. They take a drug which is targeting the fusion, that's always a good thing to go for. And last but not least, I would recommend that if possible, if accessible, that's always a point, molecular tumor boards should be taken into account when it comes to therapy decision making, because that's something that we from our daily routine see. It's not an easy thing just to get to the right therapeutic decision by just having a look on the somatic profile of the tumor analyzed. And with this being said, I again thank you for your attention, and then if it's in scope of time, it fits into the schedule, but I'm of course very happy to answer any questions. Thank you.